Hi, everyone, and welcome to the Heart of Innovation's Vascular Spotlight in partnership with vascularcures.org and thewaytomyheart.org. Today, we are featuring Ed Yu, chairman of vascularcures.org. He has extensive experience in engineering and healthcare. He's a retired partner at PwC, where he did a lot of management consulting in these fields. Now, Ed, you've been involved in the healthcare system throughout your career, as I said, but you have felt at times as though you couldn't tackle certain problems without material self-interest. What is the critical problem or a critical problem that you couldn't solve early on in your career that you feel you can do now with Vascular Cures?
Well, thanks, Kim, for this opportunity. It's great to spend some time with you. It's a great question. It's obviously also not just a professional, but a personal question in a way that I'm happy to share, which is that I've had the pleasure of working with hundreds of technology and healthcare companies in every sector, from pharma life sciences to biopharma to the payer provider side. And what I can say is that there are amazing people, very bright, talented, really all very capable of solving very complex problems. And I've learned from every one of the clients that I work with that where it sort of crystallized for me as I got towards the end of my first professional career in management consulting was that in spite of the intellectual horsepower, the capital, the resources, what we could never get around to was solving for better healthcare together. And what I mean by that is that, you go into a biopharma company, what you're trying to solve for is something around a more successful development and delivery of their drug product. If you go into a medical device company, it's similar for their device. But the problem is that at the end of the day, while all of them were working towards improving the lives of patients, I never once talked to a patient in all these patient-centered companies. And I thought, well, how do we know that what we're developing is really good for them if they're not really a part of this conversation or part of this process? And where it culminated was towards the end of my career, I had the opportunity to actually bring all these leaders together to try to solve for better health. What I realized was that everyone thinks differently. Everyone belongs to an organization, has different decision-making processes. Everyone has different priorities. And worst is that they were all talking about the patient. They weren't talking with the patient. And so, and in order for me to try to help, I had to be paid. So the question was, well, if I wanted to keep doing that, who's going to pay me? There's nothing that I could do that would be of near-term benefit to any of these stakeholders around the table. And so what I'm trying to do is to transcend what I call the silos in problem solving through a more trusted organization. And in this case, I get to do it without material self-interest in the context of a nonprofit organization like Vascular Cures.
I love the fact that you don't focus on, there are so many problems when it comes to the prevention of, the diagnosis of, the treatment of, and the long-term management of these vascular diseases. And I love that you don't focus on the fact that, this part of it isn't being solved, this isn't being created, this isn't being created. The fact is there's a lot being created. The problem is the conversations. The problem is who's at the table as part of this innovation process, and you specifically target those patients. Now, what's interesting though, is that if you talk to these companies, patients are at the table, right? In some form or fashion, they ask patients what they think. They involve patients in clinical trials, but I think what you're saying, it's the way in which they're involving them that is the problem, that when they're asking these patients these questions, they're steering the patients in the direction to go, yes, that's cool. Yes, I love it. And then they design their clinical trials to affirm that notion versus honestly saying, really, it might be cool, it might be the bright, shiny object, but will you actually use it?
Right. I think you encapsulate very well is what I call the syndrome of when all you have is a hammer, everything looks like a nail. And that is, if you're in a business developing a small molecule drug, then what you want to try to do when you involve patients is get feedback from them to validate the effectiveness of that drug. But we don't ask the question of the patient of what is it that they would like to solve for. And so in some sense, we're doing better in terms of bringing patients closer to clinical trials, but we're asking them to serve our corporate mission as opposed to us going to them and saying, how can we make your health better? And it's in that case, we got one step closer in terms of having a patient involved. We need to go to the next step and start asking the right question. And so what you're describing is what I consider kind of the innovation process and how you go about it once they're at the table.
And so is there any specific model that you've looked at in any other area that you think actually works in involving patients?
Well, I think the first thing we need to do is start to challenge our mindset about who we're talking about when we use the term patients. You know, the moment you describe a person as a patient, I think it kind of conjures up a person who is a victim of his or her disability or disease. And that just kind of connotation gives you a sense that they really don't have the influence, the authority, nor the capability to actually be involved in solving a problem. So we have to solve it on their behalf. And so the one thing I would start with is say, instead of thinking about patients, think of them as customers. And so how do you design the right health products and services for that customer, who otherwise is known as the patient? Models that are customer driven are all around us. The consumer industry, for example, is one of those. And so, and what I mean by that is that what's fundamentally different between the healthcare industry and the consumer industry is in the consumer and retail industry, it's completely customer driven. You build a better mousetrap, they'll buy more of it. In healthcare, it doesn't work that way at all. In fact, you and I probably don't even know how we pay for our healthcare exactly. We don't actually know what's in our bills. And there are many, many stories, you know, some horror stories around the payment side of things. But as an industry, it's the only industry, which is around $4 trillion in the US, where it is not customer driven. Customers are part of the process, but the services are paid for indirectly by our insurance companies. And so therefore, we're really not a part of that process in terms of developing the right kind of commercial solutions. And so I think all we have to do is, if we can just allow ourselves, start thinking of ourselves as consumers of healthcare products and services, instead of being the kind of the needy, disempowered patient, I think we start to right size the way we think about how to run this industry. So,
and I think I think that's a good, and you can hold that example for one moment, because I think you're talking about a B2B to C model versus B2B. You know, a lot of these companies develop things for, let's say, the doctor. That's still B2B. So great, the doctor will use it, but will the consumer, will the patient actually ultimately end up getting a better quality of life because of that? Yeah, great, it's easier to use, but is the patient ultimately going to benefit in a great way? So really getting to who is the doctor's customer, that's really your customer.
That's right. And there's a lot of debate about whether, you know, which model eventually is the right model. Will we move towards a B2C model for healthcare, or will it just will we try to make a B2B to C model work? There's going to be innovation around that, I guarantee us. I mean, there are people that are starting to think about that differently. But what I can say, to get beyond kind of the academic treatise on business models, is say, well, who's benefiting from the value of these services, these procedures, these devices, these drugs? And if you and I are benefiting from it, then you and I should pay for it somehow. So the question is, if you and I are going to pay for it, what's the best way of doing that? Because if there are 10 different procedures I could consume that I think would make my life better, I'm not sure that you would agree that's best for you. And we may have the same condition. And so that comes back to a customer preference and customer-driven innovation, which is, I may decide, just to use an example, if you have a risk score for stroke and heart attack that is, say, a 10%, and your doctor says, I think you need to start taking statins because it's going to maintain your risk score lower. Well, you may say, well, I just don't believe in taking drugs for the rest of my life when, there are all these side effects. I believe in science. I think the latest papers tell me it's safe to do so. I'm going to do that. And so therein lies, I think, something that we often miss when we talk about innovating better health solution, is that we again lose the customer insight in that and recognize that I'm not sure it's going to be one size fits all for every patient, every customer. And so that's really what we need to get to. And so the payment models need to flow in the same direction.
I completely agree. And I understand that hospital systems are businesses. And there's a little bit of a misnomer when people say, let's do social health care, because that's still also a business. The government still has to focus. They all focus on cost cutting, and they focus on where's the best place to spend their money. And so they're still going to have in all healthcare systems these standard protocols. But I think the standard protocols need to be revisited to ensure that it is patients over profit, no matter what is best for the patient.
You struck a chord, and tell me if this is kind of off topic, Kim, but I think it's so important, because we're right now in a part of this national debate, right? Are you on the side of private insurance, or are you on the side of socialized medicine? And what I think we miss, because there are people that love to create sensational headlines, what I think is it's a false debate. It's really a false debate. And the reason is, if you step back and say, how much do we spend on healthcare as a country, and what do we get for it? Start there. Well, we pay more per capita than any other developed nation in the world. Okay, we're at 4 trillion and counting. And we ranked, I think as of a couple of years ago, 46 in terms of the health outcomes. So you pay the most and you get like 46. So irrespective of whether you think the government should pay for your healthcare or a private insurance pays for it or your employer pays, it doesn't matter. It's a pretty bad deal. And so what we really should be focused on the energy of is, how do you make it spend either the same and get more, or spend less and get the same, right? And so that's where you got to start, because unless and until we really focus on that as a problem statement, then it's just kind of a political ping pong. And you know what? It doesn't actually solve anything.
Exactly. And that's my key point as well. Everybody's focusing on cost cutting. I don't care what you do. We have to focus on patients over that. The better patient outcomes. How do we help people to live a better quality of life, and ensure that everyone, no matter what stage of life that they're in, that they get the care that they deserve? What is best for them as an individual?
Right.
And they should be at the table to help make those decisions.
They should be at the table, and it's not one person, right? It's a diverse set of people at the table, because there are going to be minimum standards, like what's a minimum definition of just like basic care, and then what's concierge that somebody who has additional resources will pay for. And so we just need to make sure those are represented when we talk about patient engaged or patient inspired design in our next generation health solutions.
And this leads actually into my next question. How do you propose to bring all stakeholders to the table for the benefit of the patient when the healthcare industry is incredibly top heavy? Each stakeholder, from large hospital systems to legislators to innovators to patients, they all have their own top priorities, which we agree should be the patients. But as much as we would love to say that they all have those patients' best interests at heart, the standard protocols speak to the near-term profit first or cost savings approach to medicine. So how do we get all of these stakeholders to consider the long-term cost benefits and better quality of life measurements as the critical criteria in determining the next generation of innovation, adoption, and care?
Yeah, I mean, when you put it that way, it just really sounds impossible, right, Kim? And so I would love to say,
we love making the impossible possible.
Yeah, I would love to say, the answer is, small nonprofit, charitable nonprofits will save the day. Well, it's a wish. I think what you have to really be doing is think strategically. And I learned this from my business training is I always go with the judo strategy. And the judo strategy is don't try to go against the tide, go with the tide. But direct that tide towards a common vision of what is good. And in this case, where the tide is going already is that we all agree, because we're paying too much and getting too little in return for our healthcare spending, we want to move towards value-based care. We want to pay for stuff that works better in terms of improving your health. And everyone has that sort of general principle. But the problem is the key word of value in value-based care. So the question is, who gets to define that value? So if I were to ask somebody, well, tell me then what is the metric for great, good, and poor health? Who does that? We don't have a singular metric. Like if there are other industries, other disciplines where you can, like if you wanna focus on a media business, is what's your net promoter score, or what's your audience rating? There are standards around what is good. In health, because we all agree it's so complicated and we don't understand as much as we need to around human physiology and our biology, that we start to chunk it out into pieces. Let's look at neuro, let's look at cardio, let's look at ortho, and each of them has metrics around value. But the thing that's really missing around value at the end of the day, who cares? What really cares is what you consider to be good health for you and what I consider to be good health for me. And so I think that one of the things where we can start very strategically, help everybody in the industry, in the ecosystem of healthcare, to define value better. And so when we talk about vascular disease, we want patients involved in that conversation. And quality of life actually becomes super important, because when we're talking about something as debilitating as advanced peripheral artery disease, it leads to amputation. And you can imagine how one's quality of life just plummets when that happens. So the patients have a lot to say about prevention, for example, or slowing the progression, or doing exercise therapy to delay the need for vascular intervention and hopefully preventing amputation. And so every drug, every device, every payment model needs to come back to that. And so I think a place to start is to get patients involved in the definition of value.
And so what does that look like with Vascular Cures going forward? What's different about what you're doing in terms of bringing these patients to the table? And what are the critical questions that these innovators and even hospital administrators, all stakeholders for that matter, should be asking at that point?
Yeah, it's a great question. And so it kind of comes back to, you have to get very strategically focused on specifics where you can actually make a difference, a material difference. And you dream big and you start small. And so a great example in the peripheral artery disease area is the fact that when you look at something that we're trying to validate, like the effectiveness of exercise therapy for PAD patients that have pain when they walk, that it's shown that if they're supervised in their walking therapy, that it can work to improve their walking distance. And so herein is where the patients become important. The definition of better value or better outcomes in that scenario is a very strict definition based on the distance they walk in 6 minutes on a treadmill, okay? And because you can do that and repeat that setting across multiple patients, we get to define, what's better and what's not as good. But when you start to ask patients, they don't care about walking on a treadmill for 6 minutes. That has nothing to do with their real life, and there's a difference between, well, I can walk from my living room to the bathroom and kitchen and back, and that's good enough for me. But if I was a marathon runner, that's like, unless and until I can run 10 miles, that's terrible. Or if you may be somebody who only cares about being able to walk comfortably through a theme park with their grandkids rather than being in a wheelchair, that's their definition. And so how do you start to translate these sort of strict clinical settings into real life settings? Because what we care about is better health in the real world, not better health at the doctor's office on a treadmill. And so this has fundamentally started to change something we call patient-reported outcomes metrics. That is part of the definition of how we define outcomes in the PAD therapy space.
Any final thoughts?
So my final thought is this: I think we're at the start of something that could be very exciting, and this is what I would describe as a patient-centered early stage innovation marketplace. Because yes, there are pockets where we have these little wins and say, aha, when you involve in a patient, you learn something new. It kind of changes the way you think about things, and we could do research better. We can do R&D better. But really what you have to be able to do is do it in a way where it is sustained over the long haul. It's not like, well, let's just do one fundraiser or have one really cool workshop, because the way that healthcare solutions get commercialized and instituted is a pretty long timeline. And so what we want is sustainability in the way we innovate with patients, not just what they innovate. And so what I'm hoping that we can do is to create an environment where we have the diversity of patients, the diversity of industry leaders, the diversity in terms of our regulators, to have these kinds of conversations, get towards a better definition of value, and start to support these early ideas that we think really are promising, while we're trying to figure out, well, how do you pay for that prevention, for example, when it isn't part of our sick care system? And so these are going to be long-ranging conversations, but I think if we foster a community that becomes interesting to everybody, then I think we have some chance of actually getting to some really breakthrough solutions.
And to be a part of the conversation and help steer the future of the prevention, diagnosis, and treatment, as well as the long-term management of vascular diseases, you can go to vascularcures.org.